Good morning, everybody. I hope you rested well and had a good breakfast. Today is the type of day where you'll need a lot of caffeine and vitamins. It's a very, very jam-packed day. Now, before I begin, I just want to put my perspective on what this event has been so far. I don't know if a lot of you realize it, but this is an absolutely historic event. Not only is it the first NorVect conference, they've brought together some giants in the field who will probably never be together again in this kind of a conference. Dr. McDonald, Dr. Lane, Dr. Bozic, some amazing people who have been pioneers in the field, and I think you all should feel privileged to have them speak to you today. So, I'll be okay. Absolutely. So I do want to begin. What I will be talking about is treating borreliosis. Later on today, Dr. Horowitz will be speaking about treating the co-infections and the other things that happen to people with chronic illness when they're sick for a long time. But I want to start with just borreliosis. And yesterday I spoke about some diagnostic hints, and today I want to speak about treatment. As I had said yesterday, my goal is to give you the scientific and biological background of this illness so that you can make your own decisions treating your own patients, because every patient is different, every presentation is different. And so if you have the basic knowledge, then you can apply, as the slide says, logic and common sense. Things happen for a reason. If we don't know why things are happening, we have to investigate because there's always a reason for what's going on. Okay, so I have no conflicts of interest to state, no commercial pressure on me to say things or not say things. But I do also want to begin talking about the controversy in Lyme Borreliosis and how did it begin? I touched on it a little bit yesterday, but I want to go into more detail today. What is this controversy? First of all, it's recognized that some Lyme patients, especially those who have been ill for a while, don't completely recover after a course of antibiotics. Now, some believe that the Borrelia could not possibly survive the 2 to 4 weeks of treatment prescribed, and that what must be left over in these patients is some kind of a post-infectious autoimmune phenomenon. Others, including some of those in the audience today, note that the patients actually do get better if more antibiotics are given, or if they're given for a longer period of time. They do cite many, many studies, and you'll see some references on that later today. So what's the genesis of this controversy? Well, it actually dates back in America anyway to the early 1980s. Thanks to Willy Burgdorfer's discovery that Borrelia burgdorferi is the cause of Lyme disease or Lyme Borreliosis, antibiotic treatments were begun. But in those days, we didn't know anything about this bacterium. So we said, well, it's a spirochete. It must be like syphilis. So early treatments in borreliosis and Lyme Borrelia was what we gave for syphilis. And that might be penicillin orally for 10 days, some simple regimen like that. Now, the American scientific groups in the universities, I don't want to mention names because I'm trying to be non-political, those who originally thought Lyme was a Lyme arthritis and an autoimmune disease said, all right, let's try some antibiotics. We'll use the syphilis regimens. Now, they, in good faith, tried their best, and in fact, the regimens were very simple and limited, and they didn't really always work. In many cases, as you would expect, the patients did not fully recover or felt better but then started to get bad again as the infection progressed. The many patients still complained of the headaches, the pains, the encephalopathy, fatigue, so forth. But what happened, for reasons I can't even go into right now, these researchers could not publicly admit that their treatments failed. They had to come up with some explanation for why the patients who got antibiotics, who had a firm diagnosis, did not get better. But they then tried to explain it. And the way they did it was try to redefine what Lyme disease is. And this is all based on reference material. You can see actually Pam Weintraub wrote a very wonderful book about this, and that's where the reference comes from. And so what this group did was they tried to redefine Lyme as having 2 parts to it, the major symptoms and the minor symptoms. They claimed the major symptoms were the Bell's palsy, the inflammatory swollen arthritis, often of the knee, and also the carditis, which is the heart block. And they call them the major symptoms. Everything else was so-called minor symptoms. In fact, as we all know, the so-called minor symptoms are what really bother the Lyme patients the most. So they said, well, our treatments worked because these major symptoms went away. And they said, well, the minor symptoms that left couldn't possibly be an infection. We didn't fail in our treatments. So they said these minor symptoms was some kind of a post-infectious phenomenon, autoimmune, whatever. They called this the post-Lyme syndrome. But you know what? If you go back to Steer's original work before the antibiotic era, back in the 1970s, over 95% of patients with Bell's palsy have it go away without treatment. Over 95% who get a monoarthritis, that goes away without treatment. The carditis, that we all know, is transient, at least in the American borreliosis. So the so-called cure of the major symptoms is the natural course of the disease. But the minor symptoms, which we now recognize as the infection itself, they persisted. Now, if you look through the literature of Borrelia, back to the very beginning, you'll never find a consistent defect causing autoimmunity in every single Lyme patient that explains all this. And it's been decade after decade where you've seen HLA talking and molecular mimicry and other things. There's never been a consistent autoimmune disease that can be found in these post-infectious Lyme patients or post-treatment Lyme patients that would explain all of this. But back then in the mid-1980s, I recognized that when the patients had disseminated disease, in other words, beyond the stage of the rash, the 10 to 14 days of antibiotics that I gave them did help some. In fact, it helped many, but it wasn't a complete treatment. And in many cases, whatever improvement they got rescinded, and they got sick again. So I said, well, let me try it again. I gave them antibiotics. Once again, they felt better. When it stopped, they got worse again. So it said, these treatments were not enough. But I had no proof of this. It's just my trying it and trying it again. Now, it doesn't, it sounds kind of vague, and obviously in some respects it is. But on the other hand, don't forget, I was practicing in a part of New York State, which at the time was said to have the highest case rate of Lyme disease in the world. And I had seen dozens, if not hundreds of patients go through the same exact thing over and over and over again. How many times do you have to see the same illness with the same pattern and the same response before you start to see a pattern? So I needed proof of what I was seeing that was really happening. And then along came Alan, Dr. McDonald. At that time, he developed, this person right here, he developed a reliable blood culture for Borrelia. And he was able to take blood from my patients who had Lyme disease before the treatment and grow the Borrelia in his laboratory. And after work, on my way home from my office, I'd stop by his laboratory, which is in the basement of the hospital in the old morgue, this custom-made microscope, and I would look in the blood, and with my own eyes, I would see the bacteria from my patients. I saw it. And these were patients who, some were seronegative, and they had Lyme nevertheless. These were some patients who had some treatment, 10 or 14 days, but still remained sick, and the Borrelia was still there. So I had the proof. So not only did I see these seronegative patients, and at the time we thought serologies were 100% reliable, or so it was said. No one could imagine you couldn't have a disease that wouldn't show up with the immune system, but in fact, that was true. And as you heard yesterday, serologies, even with today's high technology, are very far from being perfect. Also, I saw these atypical presentations. Patients were said, you have mixed connective tissue disease. You have atypical rheumatoid, seronegative rheumatoid arthritis, dementia in a younger patient. All these so-called atypical presentations. Also, more importantly, when we studied using Dr. McDonald's culture, patients who were said to have this so-called post-Lyme syndrome, they were culture positive. They still had infection. So these were not autoimmunity, these were treatment failures. They still had it. I could not call this post-Lyme, it was still Lyme disease. So this was the very beginning of the controversy, because at the time I was working with the big universities and we were doing cooperative studies. I was in my clinical practice seeing the patients, and they were in the universities writing their papers. And we gave 3 weeks of treatment as a trial, and I said to them, the patient's coming back. They're still sick, or they got sick all over again. It's not working. And that was something they didn't want to hear. And my results were not accepted by them. And that's when I think the division started to happen, where those of us in the field who saw the patients, and with the advantage of Dr. McDonald's culture, with our own eyes, we saw the Borrelia, with the same pattern of people over and over again by the hundreds having the same response. We knew it was real. The patients knew it was real. So the universities did not want to hear that. They wanted to redefine Lyme and make believe that their treatments worked and everything was either post-Lyme syndrome or crazy patients or some new undefined illness. Another thing that happened at the time, again, this is in the mid to late 1980s, two gigantic public health issues hit America, actually hit the world. One was borreliosis, Lyme disease, and the other was AIDS, HIV. Now again, in the early days, Lyme was thought to be an arthritic condition. It's called Lyme arthritis. And the first research with Lyme was done not by infectious disease people, but by arthritis people, immunologists, rheumatologists. And they held the lock on Lyme disease. So when these two public health issues came out, what was decided in the American government was to put the funding for these two illnesses in different departments. AIDS, which was a viral infection found at the time, was given to the infectious disease branch, whereas Lyme disease was given to the arthritis and autoimmune branch. So from that day forward, the huge bulk of funding in America and probably around the world for Lyme disease research was put through as a disease of the immune system. And many of these clinics and researchers developed their reputation, their livelihood, their funding, their patents. All this financial and power was based on the myth that Lyme is an autoimmune arthritic condition and the infection is secondary. And to this day, they've never corrected that. We still, in America, fund Lyme through the arthritis branch and leave the infectious disease part out of it. All right, so having gone through that and working with McDonald's culturing, I formed my own definition of success. Number one, I concluded that the persistence of symptoms after therapy in most of these patients, in fact, did reflect ongoing infection. And my definition of success was not get rid of the major symptoms, leave the minor ones and ignore it, or say to the patient, you're crazy. But my definition was get rid of all the symptoms and have them not relapse for 3 months post-treatment. So using that very simple definition is how I went through with my practice and did my own clinical studies. Now, before I go further, I also wanted to mention that, as a number of you know, my diagnostic and treatment methods were criticized by the New York State where I practiced, and they actually put me through an investigation. And at the time, it was the largest and most publicized investigation in the history of the New York State Health Department. And the trial itself went on for nearly 2 years. At the conclusion of it, I won the case. I did not lose my license. My license was not restricted. To this day, I can still practice with no problem seeing Lyme patients. And in fact, I still practice for 7 years after that. I just left when I had an opportunity to do research. But in fact, the very interesting thing was the judge in the case at the end of the trial concluded that the debate of treating and diagnosing Lyme is a medical debate, a scientific one, and not one meant for courts and judges. So that was the end of it. And at that point forward, I was no longer harassed. And in fact, in New York State, they pretty much backed off all of the New York Lyme doctors who they were prosecuting up until that point. So even in the harshest court, which is the Department of Health in New York State, they backed off and realized that our treatments were really not that controversial, and it's really a matter of science. It wasn't a matter of the politics that everyone tried to make it. Anyway, so let's move forward. Now, why is it so difficult to treat these Borrelia infections? What's actually going on? Well, we have to, again, go back to the basics. The Borrelia growth patterns. In Lyme Borrelia, not the relapsing fever Borrelia, but the Lyme Borrelia, there's a distinct 4-week cycle of disease activities. Patients will say, we have good and bad days. I talked about this yesterday. Now, this is what happens in the Borrelia. There's a period of growth, then there's a period of latency or dormancy where they stop growing. Then they grow again, and then they stop. In Lyme Borrelia, it's about a 4-week cycle, and the relapsing fever Borrelia can be 2 to 4 weeks, sometimes 3 weeks. It turns out that antibiotics kill bacteria during their growth phase. So if you have a bacterium that doesn't grow steadily like most do, but one like this that relapses, relapsing fevers, you have a growth and a latent period. So if you use a treatment that doesn't bracket one whole growth cycle of 4 weeks, you're going to have a failure. So having this pattern and recognizing it is the key to your treatment of a Lyme patient. Okay, so again, I've said this before and I'll say it again. I'll probably say it even more. The 4-week cycle is so important. You must have your patients keep a diary. The other thing about Borrelia growth is that they grow very slowly. And it's a basic fact that the slower the growth of an organism, the longer it takes to kill them. That's why we treat tuberculosis for months, in some cases years, as opposed to staph or strep, which is a matter of days to weeks. The other things that Borrelia do that affect treatment is that they affect, in a negative way, our immune system. The Borrelia infection is immunosuppressive in mammals. They will not only cause a dysfunction of the B and T cells, they'll actually kill some of them. And as we know, they prevent the maturation of CD56 killer cells into CD57, and that's the basis of the CD57 test, which is depressed when Lyme has been active for a long time. Another thing that is very unique to Borrelia is that it causes a defect in signals from the B cells. Normally, our immune system has what's called an innate immunity, which is kind of a background immune system that's there to protect us from the very basic attack. After whatever's attacking us, the virus or bacteria, there for a period of time, we get what's called an adaptive immunity, which recognizes specifically what's going on. So the innate immunity, which is signaled by B cells, is supposed to shut down and allow this adaptive immunity to take over. There's a defect in this process in Lyme disease. The B cells don't turn off. So the innate immune system is constantly activated, and that is why we have this upregulation of cytokines, the inflammatory mediators. Well, Dr. Horowitz will talk more about that later. And the anti-inflammatory cytokines are turned down. One of the immunologists I've worked with has called this not an autoimmune phenomenon, but an auto-inflammatory process. Another thing that happens with Borrelia is what's called epitope switching. The genes of Borrelia are very complex. Some of them are turned on and some of them are turned off at any one point in time. But as the Borrelia go through their growth cycles and their latent cycles, different genes will turn off and on, and that causes the surface of the Borrelia to change. That's why the symptoms change. That's why there's a relapsing cycle. But it also means that the immune system, when it finally adapts to this Borrelia after a few weeks and starts to mount the immune attack, the Borrelia genes switch the surface, and now the body sees a new surface to the body. It's a new germ, and the old one is gone. So the immune system has a hard time catching up and getting this infection under control. So the adaptive immunity has a hard time keeping up. The Borrelia, in addition, have a lot of survival strategies. And you think about it. First of all, this bug has been around longer than us on this planet, I'm sure, and it can live in lizards, bugs, mammals, birds, so it has to be able to adapt. Now, we know, and we've seen from Dr. McDonald's work, Dr. Lane's work, that the Borrelia can shift from spiral forms, which have cell walls, to cell wall deficient forms, the L forms, and they can even form cysts, which are protective. The important thing to know from a clinical point of view is that each of these three forms has different antibiotic susceptibilities. So one medication that might work, for example, for the spiral form may not work for the other two. And that's one of the reasons why combination treatments are given. I'll show you that in a moment. The other thing is that Borrelia can sequester themselves deep into tissues and inside collagen bundles, inside the Achilles tendon, for example, far away from the immune system, far away from the effective antibiotics. That's why lower doses of medications are prone to failure, and medications that don't penetrate well will not give you a successful outcome. Borrelia are among the very few bacterium that can survive inside our cells. Now, if you have a normal situation, the bacteria get engulfed by our immune cells, and in the process of being engulfed, they're digested and they're killed. Borrelia will stay inside the cells and not be killed. So that's a way for them to survive attack, and also a way for them to be disseminated, because the blood cells travel throughout the body, they carry the Borrelia. And the final thing is that as you heard before, and you'll hear much more today, the Borrelia produce a protective biofilm. And the biofilm is like a gelatinous coating around the bacterium that prevents antibiotics and immune factors from getting to the bugs to kill them. Just some quick pictures. You saw this yesterday, some granular forms of Borrelia. Thanks to Dr. McDonald. From Dr. McDonald's work and from Dr. McClosey's work, you hear, I'm sure, a lot more about this later, the cystic Borrelia. Now, the interesting thing about the cyst is, as I mentioned before, the body will recognize and mount an immune attack against an invading organism based on the surface characteristics, the surface antigens. And it's actually these surface antigens that are responsible for the immune response. We see bands on the Western blot, for example. Well, the cystic structure has very few surface antigens, so it's almost like a camouflage around the bacterium. So if you have a cystic Borrelia, you're going to have a hard time for the immune system to find it and to fight it off. Look at this picture. These arrows show Borrelia deep within a tendon. Now, wow, how are you going to get an antibiotic in there? How are you going to get the immune system to find these individual bugs and kill them off? Now, if you go back to the original work of Dr. Alan Steer, who described Lyme from Lyme, Connecticut back in the 70s, he found the inflammatory rheumatoid form of Lyme in only about 5% of patients. But almost all the patients had what he calls enthesopathies. In other words, inflammation of the ligaments and tendons and muscle insertions. And this is where all the diffuse pain comes from in Lyme patients. It's also why Lyme is so easily confused with fibromyalgia. I mean, you see these pictures. You think about what's going on here. Oh, I could say a patient has fibromyalgia with all these body pains. So this is a very important point to understand. In our work in culturing Borrelia, we found that the only way to get them to really grow successfully is once they've established the growth in a medium, we have to put collagen there. The spirochetes must be on collagen, which is what's here in the tendons and keeps them alive. So these are one more example of how Borrelia can evade our treatments. And one final picture, this comes from American National Institute of Health, showing the Borrelia actually penetrating into our blood cells in the process of being hidden and transported through the body. A couple of quick slides on the biofilm. Dr. Sapir will show you more later. These actually are her slides. Thank you, Eva. You can see over time the Borrelia begin to pair up and then form clusters and finally thick mats. Let me show you this one. In the 3D point of view, you can see this, as Dr. McDonald said, there are channels for moving fluids in and out. You can see three-dimensional structure. Over time, these biofilms will incorporate divalent cations, calcium, magnesium, iron, and become very physically hard. They become like leather. And actually, if you press on them with the microscope, they actually crunch. They get that hard. And so you can imagine this horribly hard cystic structure, or filmy structure, very hard to get an antibiotic to penetrate, very impossible, in fact, to get the immune system to attack it. Dr. Sapi actually told me that she took this thick biofilm, so one you can see in the bottom photograph here, and actually bathed it in chlorine bleach. And after that bleach, rinsed it off and broke up the biofilm. Within the biofilm, there's still living Borrelia. The outer surface burned and formed a crust and protected the inner layer. Now, it's not all hopeless, because one of the things you have to also understand, at least in vitro, is that the biofilm is a dynamic process. The Borrelia enter it, but they also leave it. And some that stay within the Borrelia within the biofilm do die off. So this could be one reason why longer-term antibiotics are necessary, because you have to have something there to get the Borrelia as they come out of the biofilm and prevent new ones from going in. All right, let's talk about chronic Lyme. You know, there's really no firm definition that everybody agrees upon is what is chronic Lyme, and I know ILADS is working on coming up with a consensus statement. But you know, after about 1 year of illness, you start to see something change in the Lyme patient. So for me personally, my definition of chronic Lyme is a patient with Borreliosis who's been sick for 1 year or longer. It doesn't matter whether they've had treatment or not. It means if they're still sick, still infected for a year or longer, that's what I call chronic Lyme. And this is why. One thing is you start to see the immune system break down, the B cells, the T cells, the killer cells. You see the defective B cell signaling with this auto-inflammatory process going on. You see, because this B cells, which is the early immune response, doesn't turn off, that's why you keep seeing IgM being present even in late disease. And also, you know, Borrelia adapt to the host environment. We've said this over and over again. What is this? This is partly natural selection. The weaker Borrelia are killed off. The tougher ones stay behind. Active change in the genome allows it to evade our immune system, but also these recombinant effects where the Borrelia give off their DNA in little packets and signal the other Borrelia, which then incorporate it, and they communicate with each other, and they find ways to live in these environments, be it a tick or a bird or a mammal. It's again why Lyme is so difficult to treat. So when it comes to the antibiotics, we have to do everything we can using basic, again, logic and common sense, knowledge of the basics, to optimize what we're doing. We have to use the right antibiotics, and often that means combinations, especially in chronic Lyme disease. We have to use medications that will get to all the hidden spirochetes if we can. The doses have to be maximized to penetrate, otherwise you're going to have treatment failures. What I found in my work, and I'll show you some slides on this shortly, is that not everybody handles antibiotics the same way. Some people need higher doses than others, and there's no way to know unless you actually measure blood levels. I don't know if all of you can do this where you work, but in America we can do it and for many of the medications. And I'll show you a study that I did that opened my eyes to this. And the final thing is that it's illogical to limit treatment to X number of weeks and say you're cured. You don't do that for cancer treatment. You don't do that for HIV. You don't do that for any other illness. Why would you say Lyme is always cured after 2 weeks, 4 weeks, and that's it? The treatment duration has to be based on the pattern of growth of the Borrelia and on the clinical response of the patient. So what are the choices? Well, there are cell wall agents, which are great because they're bactericidal, but unfortunately they don't penetrate well. In studies in vitro, also clinical, we find that amoxicillin works better than penicillin, and that the cephalosporins of their advanced generation, at least second and preferably third and above, will work very well. In fact, they can actually work in penicillin and amoxicillin failures. Then we have the ribosomal agents such as tetracyclines. They do penetrate, but they're bacteriostatic. The only way to get tetracyclines bactericidal is to really push the dose high, and I'll show you that too. The macrolide derivatives like the azithromycin, clarithromycin, and so forth, they are bactericidal at high doses, and they do penetrate tissues and cells very well, but they don't stay in the fluids well. So the serum and spinal fluid levels are on the low side. And the final group are the azoles, the metronidazole, tinidazole for the cysts. And they're very good for the cystic Borrelia, but once they open the cyst, that's pretty much all they do. Then you have to go to one of the other agents to kill the Borrelia that now are opened up from the cyst. So to choose an antibiotic, you have to have a medication that will work in the extracellular compartment and the intracellular compartment, because a Borrelia can survive in both places. So for example, the penicillins, the cephalosporins will work in the extracellular environment, and the macrolides and tetracyclines are intracellular drugs. The antibiotics must work in the body fluids as well as deep in the tissues. Again, the penicillins and cephalosporins work in the fluids, and the macrolides are great for getting deep in the tissues. And also, the final thing is the regimen should cover all three different forms of Borrelia, because they have different antibiotic susceptibilities. The spiral form is best killed by cell wall drugs. The cell wall deficient, obviously you can't be killed by that, so you need a ribosomal agent. And then for the cyst, you need to use an azole drug. So that's often the combination that's given either all at once or sequentially to try and get the Borrelia killed off. Now, when you choose an antibiotic for your patient, is it early Lyme or is it late Lyme? How sick is the patient? What's their immune status? Which infection or infections are present? After Dr. Horwitz talks to you today, you'll get a better feeling for the co-infections and kind of balancing out what you're going to use with the combinations. So can I, for example, use one medication that will maybe kill two pathogens? For example, doxycycline for Borrelia, as well as for the rickettsial family. Will the regimen cover the spiral, the cell wall deficient form, and the cystic form? Will it penetrate the tissues? Will it stay in the fluids? All these have to be worked out. Also, you go through the history. Maybe the patient had seen another doctor before you for Lyme, or maybe they were misdiagnosed or inadvertently treated for something like a sinus infection. What was their response to that group of antibiotics? Did it make them better? Did it make them worse? Was there a Herxheimer reaction? Did it have side effects? That means don't use that drug again. So again, taking the history is just such a basic and very important thing. To understand how the different antibiotics work, there's a concept called the time-killing curve. That means what do you need to do with your antibiotic to get the Borrelia to die? Now, for cell wall drugs, again, the penicillins, the cephalosporins, you need to have bactericidal levels sustained for at least 24 and preferably 36 hours. Now, the problem is a drug like amoxicillin, when you take it by mouth, the level in your bloodstream and tissues may be okay for a few hours, but then it decreases as it excretes through the urine. So when the level in the trough gets below the threshold, the Borrelia can recover. So you need to have sustained levels. Now, the tetracyclines, on the other hand, is just the opposite. You don't necessarily need sustained levels. We need a big spike of a level to just get it to penetrate. And that's why, for example, doxycycline, if we give 400 milligrams, we don't give 100 milligrams 4 times a day. We try and give 200 milligrams twice, or even intravenously 400 milligrams once, because we want that big spike. Now, the macrolides, you can't measure blood levels because they don't stay in the blood. They go into the tissue, so that's not available as a blood level test. Now, I did a study with this. Initially, the recommendation for Lyme treatment, for Borrelia treatment, was amoxicillin, 500 milligrams 3 times a day. Well, upon advice from Dr. Bernard Berger, one of the original people who worked with Dr. McDonald and I, he said, I think you should raise the dose. So we went from 500 milligrams to 1,000 at a time, 3 times a day. And then what we did was we added probenecid to the regimen, also 3 times a day. Probenecid is not an antibiotic, but it prevents the excretion of penicillin. Our kidneys have penicillin pumps that will pump the penicillin out into the urine. If you take probenecid, the body will pump out the probenecid instead of the penicillin, leave the penicillin in. So it's a way of maintaining not only a higher peak, but a higher trough level of the antibiotic. So by raising the dose of amoxicillin and adding probenecid, success rate of this regimen doubled. So that became the standard. I did a study cooperatively with Stony Brook in New York State, using doxycycline 300 milligrams a day in early Lyme, and there was not a single success. 100% failure rate of 300 milligrams a day of doxycycline. 100% failure rate. It's been found that doxycycline, if you don't get high tissue levels, you're not going to kill Borrelia because it's bacteriostatic at low levels, bactericidal only at high levels. Again, I'll repeat this, 300 milligrams a day, which is still higher than what IDSA recommends, in my studies did not have a single cure based on my definition of cure, getting rid of all the symptoms, major and minor, for at least 3 months post-treatment. So then what I did was I did a study, and this was reported at one of the major Lyme meetings in Boston, where I took patients, I matched them for age, gender, and weight, and I gave them all the same doses of the same brand of drug. I did once with amoxicillin, probenecid, the other was with doxycycline. I then measured blood levels, both the peak and the trough. And with the amoxicillin probenecid regimen, there's a 100-fold difference between the highs and the lows. Some patients absorbed it well and maintained it well, and they had peak levels in the teens up to 20s. Others had a peak level of less than 0.1. So I would never know this. The patients are matched by age and weight and height, and we had 100-fold variability. So from that, I said, you must measure blood levels if you can. Doxycycline, there's a 10-fold variability. It's been said doxycycline fully absorbs. Well, in my studies with a large number of patients, there's over 37, I believe, patients in the doxycycline arm, 10-fold variability. I found that IVs gave higher levels than oral. It's been said doxycycline's fully absorbed. Well, in a Lyme patient, it's not, and I've proven it with my studies. Let me give you a little bit of a case history. I had a patient who knew Lyme very well. Her father had it, and she lived in a Lyme endemic area near where my office was, and she developed an EM rash, and because she was a busy mom with young children, she couldn't come in right away, so she came to me by the time the rash had already faded, but still some remnants of it, and she's starting to have systemic symptoms. I put her on cefuroxime acetyl, which is ceftin, a very good cephalosporin of advanced generation, works even when amoxicillin doesn't, and she was on the treatment, and she really wasn't getting better. So I said, give it a few more weeks, maybe it's Herxheimer. A few more weeks went by. She's on treatment maybe 6 or 8 weeks, and she still was really not getting better. I said, all right, let me do a blood level. Her peak level of cefuroxime, and the levels you want to get to, like in the mid-teens, her peak level was 0.1, 0.1. Now, if I didn't do that level testing, I could have had her on this long-term treatment, chronic Lyme disease, failure of therapy. I did the blood level. I found she wasn't absorbing it. I switched to the doxycycline, 400 milligrams a day. Her level on doxycycline was in the mid-teens. Within 6 weeks, the symptoms cleared and never came back. So the moral to the story here is that things happen for a reason. If the patient's not getting better, go back to the basics. It's pharmacology. We all learned this in medical school. If the medicine's not working, there's a reason for it. Maybe the level's not high enough. So when it's available, I always recommend blood level testing of the antibiotic. So the dosages for oral antibiotics, as I said, we start with amoxicillin 1 gram every 8 hours, and to that we add 500 milligrams every 8 hours for probenecid. Pediatric dose, of course, is based on body weight. Cefuroxime acetyl, commercial name is known as ceftin. It's recommended 500 milligrams every 12 hours for sinus and skin infections. In my blood level studies, I found that was not adequate. My starting dose in a Lyme patient, in an adult Lyme patient, is 1,000 milligrams every 12 hours. And again, you need to check levels, and you may have to add probenecid to get the trough levels to stay up. Ceftonir, which is now a generic, it used to be called Omnicef. Again, the recommended dose for routine infections is 300 milligrams every 12 hours. In Lyme, we needed 600 milligrams every 12 hours. And again, you may need to add probenecid. For the tetracyclines, there are restrictions on pregnancy in children, but plain tetracycline, which is hard to tolerate, you start with 500 milligrams 3 times a day, may have to go to 400 milligrams. Doxycycline, as I said, you start with, in adults, 400 milligrams a day, and very often my patients, because of blood level tests, will need to go higher to 500 or 600 milligrams a day if they can tolerate it. Likewise, minocycline, you want to get to 400 milligrams a day if the patient can tolerate it, which very often they can't. Minocycline also has a very long half-life, so if they start to get side effects such as vertigo, upset stomach, it takes a long time for it to wash out, and that's difficult, and it actually can affect liver enzymes, so you have to watch your patients. But if you don't push the dose, you're going to have a treatment failure. Now, the erythromycin group, the azithromycin and so forth, there is concern about cardiac effects, and it's very simple. Do an electrocardiogram before treatment and measure the QT interval on the cardiogram. If it looks prolonged, either don't use the antibiotic, or if you put them on the antibiotic, repeat the cardiogram once they've begun and see if the QT did in fact prolong and put them at risk. Monitor the liver enzymes and so forth. Look for interactions because it can affect the CYP 3A4 in the liver and affect the blood levels of other drugs. Anyway, azithromycin by mouth, I'm quite disappointed with in American Lyme. I found you need at least 1,000 milligrams a day, if not higher, for it to do anything for my adult patients. Clarithromycin, which is known as Biaxin, we start with 500 milligrams twice a day, usually go up to 3 or 4 times a day. Now, a quirk about this drug, patients who've been on this will tell you that they get this terrible taste in their mouth. Now, this is just my thinking. And again, it's not scientific. This is my disclaimer. But my thinking is that the taste is not from swallowing the pill. It's from the blood level getting inside the bloodstream and affecting the taste buds from within. And I've found in my patients that if they don't taste it, it seems to not work. So maybe that's a sign of the blood level being low. Contrary, if the blood level is very high, they taste this terrible taste all day long, and I know I can back off the dose. So this is a little bit of clinical feel for Lyme disease that you'll learn as you go. Telithromycin is a drug named Ketek in America. I don't know if you have it here in Europe, but I found it to be by far the most effective but also most toxic drug for Borrelia. It's a ribosomal drug that works against 2 different ribosomal locations. It's very well absorbed, and it really does an amazing job of killing the Borrelia. And I've had chronic patients sick literally for 10 years go on this as a single agent and have the worst Herxheimer of their life that lasted literally for weeks. Other patients who got so rapidly improved that had been on pain medications, they stopped the pain medications abruptly, went through narcotic withdrawal. So it's a dramatically effective drug if the patient can tolerate it. You really must watch the cardiogram and especially liver enzymes. Now, for intravenous therapy, we start with standard dosages. You can't really measure blood levels of ceftriaxone, but you can for intravenous doxycycline. And if you ever use the drug vancomycin, which is not a first-line drug at all, but it can be used, you can measure blood levels for that. You may have to modify the dose. For example, the patient may have trouble tolerating it because of leukopenia, which can occur during the Herxheimer reaction, liver enzymes, and so forth. And there's a thing called pulsed dose therapy, I'll show you a slide on, which allows you to change the dose in a higher level to get better killing. What about treatment duration? The thing we learned in Lyme that's chronic and long-standing is you really need a long duration of therapy. Why is that? First of all, bacteria are killed during their growth phase. Borrelia will not grow steadily. It grows in this magical 4-week cycle, sometimes a little bit shorter. So if you don't have a treatment regimen that brackets this whole 4-week cycle, you're going to have a treatment failure because some of the Borrelia will wake up when the antibiotic is no longer there. So for me, the minimum treatment has to be at least 6 weeks to bracket one whole 4-week cycle. Why 6, not 4? Because the Borrelia take time to be affected by the antibiotic. Time-killing curves, 36 hours. They start to be killed off after the first day or 2. The Herxheimer reaction doesn't happen with the first dose. It happens maybe into the 2nd or 3rd day. So once that has settled down, you count ahead to the next 4-week cycle. When that 4-week cycle is clear, that's when you can stop the early treatment. Now, if someone comes to me with an asymptomatic erythema migrans rash, I will start the 4-week treatment. If they never get symptoms and the rash fades and they feel fine, the 4 weeks for me is all right. If they are asymptomatic but you put them on medication and they have a Herxheimer reaction, now those are symptoms. When those symptoms stop, then I count ahead 4 weeks. Okay? So again, for symptomatic Lyme, I find the minimum treatment is 4 weeks. Now, because Borrelia grow very slowly and the doubling time is comparable to tuberculosis, which is again treated for months, in some cases years, you may need to treat disseminated late Lyme for also months. Now, I did a study, and this is back again in the 1980s, when we found the higher dose of amoxicillin was better than the lower dose in adding the probenecid. I put patients on different length of regimens, and these were patients who had disseminated Lyme, but not chronic Lyme. They were sick, but not sick for more than a year. They had intact immune systems as far as I could see. And I tabulated their percentage of success based on the duration of treatment. If I gave this dose of medication for 1 month and then stopped and followed them and saw what happened after 3 months, only 17% got well and remained well. If I raised it to 2 months, then 3 months, and 4, the percent success rate kept improving. It hit a plateau of about 67% at 4 months for males and at 6 months for females who are hormonally active. So in my hands, the amoxicillin for disseminated Lyme at this dosage had a success rate of 67%, provided you went to that endpoint of 4 to 6 months. Now, I did a study with the help of Dr. McDonald with intravenous antibiotics. I took patients who had disseminated Lyme disease, again, not the chronic form, just disseminated, 26 patients. They were culture positive for Borrelia, clinically had Borrelia as well. Gave them 14 days of intravenous ceftriaxone. Some got 2 grams a day, some got 4 grams a day, which is double the recommended initial dose. As soon as the treatment ended, we cultured them, and all cultures were negative. However, over a period of time, the patients 3 weeks later, 4 weeks after treatment, they all started to get their symptoms back. As the symptoms started to recur, cultured them again. Every single one, 100% of them was culture positive. So 100% failure rate of 2 weeks of ceftriaxone based on culture results. Actually, if you look at the literature, you can see the same thing. So what I recommend personally for IV therapy for Lyme patients is to do, again, bracket this 4-week cycle Borrelia. 6 weeks of IV therapy is minimum, okay? Now, during the course of treatment, there will be a Herxheimer reaction in the beginning. Then things will settle down. By the third week of treatment, the patients actually feel better. Into the fourth week, another crop of Borrelia come into their growth phase. As they're growing, they're now being killed off. There's another Herxheimer-like reaction at week 4. Sometimes it's even worse at the fourth week than in the beginning. What I find is that if there's a large reaction at the fourth week, I know I'm not through with the IV. I'll go for another 4 weeks until we find the point where the reaction is not that severe. Then I can stop. But I don't stop treatment altogether. I may stop the IV, either because of tolerance or insurance and so forth. But I will get the patients to continue treatment for at least that 4 to 6 month point, either by going after the IV onto intramuscular or oral therapy to finish off that course. In fact, there's literature on this now, published last year, where they found, and I read it to you, prolonged intravenous antibiotic therapy is associated with improved cognition, fatigue, and myalgias in patients referred for treatment of neurological Lyme disease. These patients were treated with IV for 25 to 52 weeks. That's up to a year of IV therapy. And that's what was necessary in this group that's been published. Now, does everybody need IV therapy? Do you have to do IV to get better? Dr. Fallon, as you know, had done a very difficult NIH study using intravenous antibiotics. But before he did that study, he needed to do a pilot study as a proof of concept. So this is what got published. He took patients with chronic neurological Lyme disease and gave them different treatments. He gave some of them placebos, and as you would expect, it did nothing. He gave them oral antibiotics, and some symptoms seemed to improve, but it really was not statistically significant. Intramuscular penicillin, benzathine penicillin, in an adequate dose actually worked pretty well for a lot of the patients, but again, it was not as good as the IV therapy. That was by far the most effective. So I said to myself, okay, how do I as a clinician know which patient to put on IV or not? Is there a marker? Is there a guideline? So what I did was I closed my office for a whole week. I had all my staff stay there. We took all our charts. We piled them up on every desk in every room, and we went through them. And I found out of this group 633 patients who I could study. And I went through them all. And I found, okay, out of this group of 633 patients, going back in time and looking at what their situation was, which were the ones that eventually had to do IV therapy to get better and which ones did not need IV therapy. And what comes up on this list is what came out to be statistically significant. If the spinal fluid was reactive, and I don't mean a positive serology, but I mean white cells elevated or protein elevated, that's a sign that IV therapy at some point would be needed to get them over the Lyme. If they had the rheumatoid form of Lyme with a high SED rate and very swollen joints, that's another group. Illness more than 1 year. Again, is this now the chronic Lyme? Are these the patients who have immune dysfunction? Age over 60, as you can imagine, would be expected. For pregnancy, of course, in the first trimester, if there's an acute disseminated illness, nobody fools around with that. They do IV therapy. It's also carditis, and my research showed that it was true. If there's a documented immune deficiency, either because of the patient was born that way, or if they were given, for example, high-dose steroids or cancer chemotherapy while they had Lyme, that sets them back, and these patients, as a group, needed IV therapy. Obviously, if someone couldn't tolerate oral therapy or IM, then IV is the way to go. Now, the different types of schedules of IV therapy. Standard therapy, most of you know about. You give the dose once a day, 7 days a week. For example, ceftriaxone, 2 grams once a day, 7 days per week. There's an alternative to this, which came actually out of Germany in the 1990s, and they took a group of patients who had the standard 1 month of ceftriaxone, 2 grams a day, or cefotaxime clavulan, 6 grams a day for a month. And their patients, not all of them got better, and those who did not were cultured, and they were culture positive. So they said, how could the Borrelia survive? Maybe we need a higher dose. But how can you give a double dose of antibiotics and do it safely? They came up with a regimen called pulsed dose therapy, which I now embrace. What they do is they gave a higher dose. In the case of ceftriaxone, they gave 4 grams a day. But instead of giving it 7 days a week, they gave it 3 days in a row. Actually, they gave it 2 days in a row. I usually give it 3 days in a row. Now, why is that? Again, it takes, for a cell wall drug like this, 36 hours of sustained levels to kill the Borrelia. So you can give this medication for enough time to really hit the Borrelia. Now, if you stop treatment, it takes a whole month for them to regenerate. So you can be off half the week and give the body a break, give your immune system a break, allow the normal flora to come back, and you have therapy that's probably more effective because you can use double the dose. So for example, ceftriaxone is not 2 grams once a day, but 2 grams twice a day, 3 days a week. But the 3 days have to be 3 days in a row because you want those sustained levels. Now, what I find to be really good about this is that not only can you take a higher dose or maybe possibly a more toxic drug like vancomycin, but allows you to tolerate the treatment better. First of all, half the week or more, you're not on any antibiotic. Gives your body a break. It allows you to use a peripheral line and not have to do a long central PICC line. If you look in the literature and in your own experience of treating Lyme with IV therapy, you look about side effects. The side effects don't come from the drug in general, it's from the long IV lines. So if you put a heparin lock in, you can tolerate that for 3 days, and you can get the treatment you need, in fact, the double dose, and have it in for 3 days, and the rest of the week it's out. You can bathe, you can go swimming, you can take a shower. Also, this is the trick when someone has a strong Herxheimer reaction. Don't cut down the dose of full round. Just totally stop. Let the body calm down, because again, it's going to take a month for the Borrelia to regenerate. And you can do this type of pulse therapy in oral medications as well as IV. Now, there are exceptions. For example, the azole drugs, that's metronidazole, flagyl, and tinidazole, their time-killing curves indicate you need pretty much 14 days of continuous therapy. Now, these drugs are very difficult to tolerate, and many patients can't do 14 days in a row. So you might do a week at a time and stop. Then as they start to improve, you can tolerate 10, maybe 14 days at a time. And what I like to do with my patients is give ideally 14 days on and 14 days off. So you're working with the Borrelia cycle, and also you're giving them a good break. Now, azithromycin, you can't really do pulse therapy because it's such a long half-life. However, when given it IV, you can give it 5 days a week and not the weekends. Give the patient and your on-service call a break. Long-acting IM penicillin, by definition, can't be pulsed, but also understand that this is a treatment for Borrelia. You can't use pulse therapy for many of the co-infections. There's another type of therapy which people don't often hear about because it's something I invented, actually discovered by mistake. Not by mistake, it was just something I tried and it actually worked out. It's what I call cycle therapy. I've had a number of patients who go on treatment and they improve to a certain level and then they're on a plateau. Now, what's this plateau? They still have symptoms, they're not as bad as they were, but they're not completely back to normal. If you stop the treatment altogether, they start to get worse. You put them back on treatment, they improve to a plateau. How do you break the cycle? Well, think about it. To kill Borrelia, you have to kill them in their growth phase. Now, if you're on a treatment plateau, you're kind of in a stalemate. The Borrelia aren't growing, but it means they're not being killed, and you're sort of just pushing at each other. So what I would do would be, when the person, not in the beginning of Lyme treatment, but when they've hit this plateau, to break the plateau, I would totally stop antibiotics. Now, what would happen? The first few days, the patients would feel better. The drug is out of their system. There's no more Herxheimer stirring up. They'd start to feel better. But about the 3rd week, they start to feel maybe something's coming back. By the 4th week, they know the Lyme is there. What's happening? The Borrelia are back in their growth phase. Now they're vulnerable. You broke the plateau. Put them back on full-dose antibiotics. Induce a Herxheimer reaction. Get the bugs to be killed off. They'll have a Herxheimer reaction. And then after a few weeks, it'll all start to settle down. And then they get back to their plateau. When they're on that plateau again, you stop. And let the cycle repeat. And generally, it works out for Lyme Borrelia, which is their 4-week cycle. It generally means about 5 or 6 weeks on treatment and then off 3 or 4. And you go by the symptoms of the patient, not arbitrarily by a calendar. It's based on the patient's symptoms, especially if you have a relapsing fever type Borrelia, which might have a shorter cycle. And what I found, if you time this right, it takes about 3 or 4 cycles, and the patients will have this last Herxheimer, feel better, and not get it over, not have the Lyme come back, and then the treatment ends. I myself had Lyme disease, and that's how I broke my pattern. Some of my patients, including one who wrote a very important book on Lyme, Pam Weintraub, she talks about it, and that's how we broke her cycle. And interestingly, when I was on antibiotics, I was on cefuroxime orally after courses of IV, and I was on 26 weeks. And I started cycling it. And at the 3rd cycle, I had the strongest Herxheimer reaction I've ever had, even stronger than on IV therapy. And when that settled down, it never came back, and the Lyme was gone. So this is not, again, for every Lyme patient. This is for those who've hit this treatment plateau, and it's a simple way to break the plateau. Also, what I think is that now that we know about cystic forms, it might take some time for cysts to form, but also may take time for them to open up. So if you have someone off treatment a number of weeks, cystic forms may have gone back to spiral forms, or at least open up the cyst, and now they're more vulnerable to treatment. So for whatever reason, and this is just something we found empirically, I've seen it over and over again in my patients, just a little trick to learn to help to break some cycles. So there are other drugs you can use intravenously, cefotaxime, Primax, which is imipenem, meropenem here in Europe, not quite as good. Ceftaroline is a fifth-generation cephalosporin, has been demonstrated to work in rocephin failures. Vancomycin has been also shown to work in cephalosporin failures, but it's not recommended as a first-line drug. Turns out Borrelia have beta-lactamases, penicillinases. They also have cephalosporinases. Now, these are very slow-acting enzymes in Borrelia, and you can overcome them by a higher dose. But in some cases, you can't, and you have to use a drug like vancomycin or ceftaroline, which gets around this. When doxycycline is given, again, for Lyme, you want a big spike of a dose. So if you're doing an IV, we give 400 milligrams once a day, 7 days a week, and you check the levels. Azithromycin as an IV works far better than it does orally in my hands, and we give it once a day, 5 to 7 days in a row each week. And for any of these, you can add an azole drug to bust open the cysts. What about the Herxheimer reaction? As the spirochetes lyse, numerous bacterial toxins are rapidly released, and it initiates a cytokine cascade. The patients feel worse. What does that mean? Symptoms they are currently having can get worse. Old ones that went away can come back, and even new ones can appear. And as a clinician, sometimes you're not sure, is this a drug side effect? Are they becoming allergic, or is this part of the Herxheimer reaction? Sometimes you really don't know. You have to follow the patient to see. But again, looking at the patterns can help you. It usually begins a couple of days into treatment, will last several days, maybe even a week or two if the patient's very sick. And it will recur every 4 weeks. So if you have a patient keeping a diary and the first week they have a flare-up, 4 weeks later there's another one, 4 weeks later there's another one, you can start to see, well, this is a Borrelia pattern. It's probably not a side effect of the drug. Now, I always do liver enzymes and blood counts every single week in the first month or two to make sure the patients are tolerating this well, because you can see leukopenia during a Herxheimer reaction and elevated liver enzymes. So what do you do about Herxheimer's? Well, the patients who are more ill, who've been sick for a longer period of time and more debilitated, are the ones with the worst Herxheimer's. Now, as Dr. Bosick said yesterday, we don't take a new Lyme patient and hit them right away with treatment. What we have to try and do is resuscitate them from being so sick. So when I first see a patient, I don't get them on treatment the first visit. Often I'll do things like get their nutrition fixed, or work on clearing out yeast, work on getting their immune system built up, get their body in better shape so they can start the treatment. And that will help to minimize the Herxheimer's and give them better treatment outcome. Patients with severe neurological conditions, you don't want them to Herxheimer severely, so you don't want to hit them so hard with antibiotics. Likewise, elderly and chemically sensitive patients and those who are co-infected. But now these again are for patients with a chronic form of Lyme. For early stages of Lyme, the Herxheimer's are something that's better tolerated and often doesn't have a problem. Now, here's the dilemma. How do you manage a Herxheimer reaction? If you give a lot of antibiotics, strong antibiotic in the beginning to really hit the spirochetes and do your job of killing it, sometimes the reaction's severe, and it might scare the patient, might scare you as a clinician. Say, I don't want to do that again. I'm not going to do that. And some patients will say, don't ever give me antibiotics. I want herbs. So that's not good. But on the other hand, unlike what had been said earlier in the literature, it's now known, according to work by Ben Luft, that Borrelia can rapidly develop antibiotic resistance. Okay? So what's been found, and certainly my studies have shown this, studies by Dr. Cameron published have also shown this, if you have a patient who's undertreated by giving too low of a dose, like doxycycline, 200 milligrams a day, their Lyme becomes much more difficult to treat in the long run. That makes sense. Again, logic and common sense. You have a sub-therapeutic regimen. You're going to kill the weaker Borrelia and leave the stronger ones behind. You're going to kill the superficial ones and leave the deeper ones nice and deep. So in addition to that, you're developing drug resistance. So how do you reconcile the dilemma of a strong drug, a strong dose, a big Herxheimer, and scaring everybody, or a low dose, but then you maybe develop resistance? Again, goes back to the pulse therapy. Give the treatment 2 or 3 days. If it starts to build up to a Herxheimer, totally stop. Let it calm down. Then you can go back on the treatment. If it starts to build up, you stop. Let it calm down. I had one very sick patient who had a combination of ME and Lyme, who was very chemically sensitive, and she was on she's on by accident, clarithromycin, 1 day a week for, well, it was probably about a year and a half. And she took it just 1 day a week, and it managed to get her through Herxheimer's and completely recover, go back to school, go back to work. But otherwise, she would never be able to tolerate the treatment. So the Herxheimer reaction is something you need to learn to take care of and also to recognize. Now, some patients, they might get a weird reaction, weird such as a rash or hives. Now the question is that allergic reaction that developed, or is that part of the Herxheimer? Well, I had enough of this happen to my patients. I engaged my local allergist who did objective studies and actually published on this, where he gave the patients skin testing with the very same antibiotic that they had with the rash, And the study showed that 87% of the time, they were not allergic. It was a Herxheimer reaction. So our procedure was if someone starts to get a hive-like rash from at the time of a Herxheimer, treatment would be stopped, let everything calm down. Usually about 4 to 6 weeks later, when everything settled down, they would see the allergist, do the skin test. If the skin test was clear, we'd give a very tiny dose of the same medication in the medical office or in an emergency setting so that in case a person had anaphylaxis, you can manage it. And if the small dose was tolerated, then the next dose would be a standard dose, but again, fully monitored for the whole time it was given, and that's fine. Then the patient went back on IV. Now, let's say you have a patient on IV. How do you manage this? Again, the 4-week cycle will guide you, okay? So IV therapy minimum is 6 weeks to bracket one whole cycle of the Borrelia growth. Now, how long do you keep them on IV? In the ideal world, let's say where insurance and financial issues weren't involved, what do? Again, you look at the Herxheimer reactions and the 4-week cycles. If the 4th week is a really strong Herxheimer, very strong reaction, to me that indicates you have a lot of Borrelia still left, you're still doing a lot of killing. Keep the treatment going to the next 4-week cycle and keep doing the IV to the point where the 4-week cycle clearly is diminished, and between the cycles the patients can say, I'm finally feeling a lot better. Then at that point, you can stop the intravenous and put them on oral to follow it through, or IM, or combination of the two. Another thing that we've done is to try and minimize side effects of ceftriaxone. Ceftriaxone is a unique antibiotic in that it's excreted through the bile, and it can crystallize in the bile and cause stones in the gallbladder, or even just sludging of the gallbladder bile. So what we've done is, number one, pulse therapy. Means, again, you're on the antibiotic less than half a week, allows things to clear out. And number two, we give them ursodiol, which is used to dissolve gallstones, and in this case, as a preventive. Now, I don't have any formal study on this except to say that since we started doing this, we've not had a single case of gallbladder problems associated with ceftriaxone. Let me give you another story. A lot of my Lyme patients had gallbladder troubles who never had ceftriaxone. So what is that? So I worked with Dr. Perlmutter in Florida. She's an old friend and moved to Florida to do her Lyme treatments. And she had seen the same thing. So what we did was the next 4 patients who had gallbladder troubles, who had Lyme disease, but who had never had antibiotics, we had their gallbladders analyzed. All 4 were PCR positive for Borrelia. So maybe there's something about the microenvironment of a gallbladder that favors Borrelia. And maybe part of the cholecystitis in Lyme is not really a side effect of ceftriaxone, but a sick gallbladder from the disease. But it's funny that 4 out of 4 cases were PCR positive in gallbladder tissue. All right, so as I said before, when I have my patients on IV, we always do a blood count and liver enzymes every week in the beginning, at least for the first 4 weeks, then less often if things are fine. Now, I'll give you some examples. We can use IM therapy, intramuscular antibiotics such as benzathine penicillin. The benzathine penicillin, as you know, is a long-acting depot form of penicillin. This has another interesting story. It turns out that the first published reports of this came out of Italy back in 1990, 1991, where they gave 1.2 million units once a week. And the patients had some improvement. So we started to try it in America, and I saw some of my patients, they did a little bit all right. Not great, but they did all right. But it wasn't such a terrific thing. I had an occasion of one patient came in, husband and wife, who were from Eastern Europe, and they came to America as immigrants. The wife had been a physician in Eastern Europe, but did not have a license in America, so she couldn't practice, came to me to treat the husband. Husband was terribly sick. He couldn't speak a full sentence. He was confused. He had tremors. And for whatever long story reason, we decided to put him on IM bicillin, the 1.2 million units once a week. And the wife, as a physician, gave him the shots. Well, they disappeared, and I hadn't come back for treatment. She wrote her own prescriptions, had someone write the prescriptions, and I lost them to follow-up. About 4 or 5 months later, he showed up with her, completely well. He could speak, he could move, he was smiling, he was a completely different person. I said, what happened? How did this happen? And the wife said, if a shot a week was great, I figured, why don't I do 1 shot a day? She gave him a bicillin shot every single day for those 4 months, and he completely recovered. So now I looked into it. 1.2 million units of benzathine penicillin is only 1,000 milligrams. So if we give amoxicillin 3 or 4 or 5,000 milligrams a day, he's using 1,000 milligrams once, 2 or 3 times a week. It's a very tiny dose. But the thing is, it's a constant level. Anytime a spirochete comes out of hiding, out of a biofilm, out of a cyst, there's some background penicillin there to hit it. So for me, this is a great foundation of therapy. You can put the patients on this. If you give the injection carefully, they're not going to have a bad reaction at the site. They can tolerate it well. There's not a yeast problem. There's no GI issues. It's a great medication to use in a pregnant woman because, again, morning sickness, they might reject some oral antibiotics. Now, as a foundation, you can add to this some macrolides. You can add an azole, even probenecid. If you don't want to give the shot 3 times a week, you can do it twice a week with some probenecid. How am I doing for time?
A little late.
Oh, my goodness, I'm not even halfway through. All right. Yesterday I went so fast, I figured today I'd take my time. All right. Oral antibiotics, as I mentioned, cefuroxime, I like to start with 1,000 every 12, amoxicillin 1,000 plus probenecid every 8, doxycycline at least 400 milligrams a day, check the levels. You can add macrolides to this. Dr. Horowitz will tell you about using combinations like that. You can add an azole. Pregnancy. Now, if the patient gets a tick bite during pregnancy, it's considered high risk, and you really want to treat them, even if you don't think the tick, even if the patient doesn't have any M. rash, just as a prophylactic, because you're treating the mother and the baby. For active Lyme, IV or IM therapy is given. You can add azithromycin, which is safe during pregnancy and is also a good thing to do. You want to treat for the whole duration of pregnancy through to delivery. You want to test the cord blood by PCR or culture or both. You want to look at the placenta by a pathologist. It's not often done, but look for placental inclusion bodies, which show that there's a risk for health issues of the baby, and it's a 50% relationship to autism. Breastfeeding. Dr. McDonald and I did a study. 4 women who had EM rashes during the late phase of pregnancy refused antibiotic treatment. After the babies were born, we tested their breast milk. 2 had cultures, 2 had PCR. All 4 were positive. So what does that mean? An untreated Lyme mother breast milk could be infectious. Again, it's just 4 cases, but 4 out of 4 are positive. Now, if the patient was treated, maybe that's different. But you see, the problem is, if you as a mother have the situation, you would feel awfully bad giving your baby Lyme disease. We just don't know if giving the mother antibiotics will clear the breast milk. We don't know anything about that. So it's a long discussion between you and the patient, and you have to just hit the pluses and minuses. And of course, the child you should follow carefully. Pediatric dosing is based on body weight, but note that the drugs in children have a shorter half-life. You have to shorten the intervals. Can't give doxycycline in the very young. If you're giving macrolides, check the cardiogram for QT interval problems. Monitor side effects. Children are bad historians. You have to be proactive in getting them to tell you the truth. Now, how do you know if your treatment should be continued or stop? What are the signs of an active infection? The 4-week cycles. Things come and go. That's a cycle of Borrelia, not a cycle of humanity. If the symptoms are migratory, that's a Borrelia changing its surface antigens. Low-grade fevers in the mid to late afternoon. Patients with Lyme know around 3 o'clock, 2 o'clock, they get this fade, they get, feeling flushed, feeling tired. That's when you find Borrelia in the blood, you find a low-grade fever. If the elevated C4A came from Lyme, if it was normal before, now it's elevated, that's the way to monitor it. And if they're not on antibiotic therapy, you can do PCR testing and culture. Even if there are antibiotics, if they are on and they're having symptoms, you can find antigen in the urine, so that can be a useful test. And when do you stop? Again, the 4-week cycles. The minimum treatment, as I said, for me is 6 weeks for active Lyme to bracket 1 whole cycle. Continue to treat until the 4-week cycles disappear. Have them keep a calendar where every month is a page, and you check off good and bad days, and you can get to predict. You say, oh, look at that. The second week of the month is the time you expect it to flare. So you get them to the point where they're pretty much well all the time, and when that week comes when they should flare and they don't, now the Borrelia is controlled. Now you just continue for at least another cycle to be sure they didn't miss one. Some doctors will go for 2 or 3 cycles, depending how sick the patient was. And if they have really continued to be well, then you can stop. Symptom diaries. Question I get all the time, can we cure chronic Lyme? Well, we don't really have a way of proving a cure, but you know what? I don't know if you really have to. We harbor a lot of pathogenic organisms in our body. It's this balance between our immune system and the pathogens. We can weaken the Borrelia with antibiotics, but we need to build the body up with supportive therapy. Dr. Horowitz will talk great length about this later on today. So most patients will be treated until they are symptom-free for a good 6 weeks, sometimes even longer, and the treatment response varies. Now, you as clinicians are hearing these talks today, and especially later on you hear some really intensive type of treatments. It might scare you a little bit, say, I don't know if I really want to do this. Well, you don't have to treat every single patient for 1 year of IV antibiotics. We don't do that in America, so I don't think you need to do that either. It depends on the patient. Some practitioners feel comfortable giving open-ended antibiotics till the patient really finally clears. Others will give a 6-10-week course and stop and see how the patient does, knowing that they might relapse and have to go right back on treatment again. So do what's comfortable for yourself and what's comfortable for your patient. Don't get yourself locked into any one treatment regimen. What about treating a tick bite? That's not a simple thing to answer. Did the tick come from an endemic area? Was it the type of tick that could transmit pathogens? How deeply was it attached? Was it engorged? When it was removed, did it come out in one piece? Did it break, spilling the contents into the wound? I mean, the tick could have been on for only 1 hour. If it's broken up and the contents get in the wound, that could cause an infection. If the patient's pregnant or immune depressed, you may want to think more about giving treatment than not. Now, if you are going to give treatment, you don't fool around. You give a full dose. As I said yesterday, even in early Lyme disease, the Borrelia disseminate into the blood, into the central nervous system, into the organs within hours to days. So every treatment, even for early Lyme, even prophylactic, is full dose therapy. You don't say, well, it's early Lyme, I'll just give you 200 milligrams of doxycycline. If you're going to treat it, you treat it completely. And you have to offer follow-up because, a patient may end up having troubles later on. There's publication in America to give a single dose of doxycycline after a tick bite, and it said it worked. Well, did it work? The endpoint of working was that the patient did not get an EM rash, which a lot of them don't anyway. They didn't follow them beyond 6 weeks. Who knows, if 2 or 3 months later, they might have come down with some kind of a problem. So again, follow-up is very, very important. Let me just give you a quick hint on treating EM rash. What often we do is give doxycycline because it covers the rickettsias, the Ehrlichias, anaplasma, as well as Borrelia. But it's not that great at covering Borrelia. As I said, even 300 milligrams a day really was not successful. You have to give 400 milligrams a day, and that gets hard to tolerate. It may not always work, especially if you don't have time to check blood levels. So what I've often done is what's called a hybrid regimen. I'll give 2 weeks of doxycycline because that's really all you need for early case of rickettsia anaplasma, and follow up the rest of the 2 weeks with amoxicillin, probenecid, or cefuroxime because that works better. In chronic Lyme, how do you manage it? It could be active infection, could be autoimmunity, could be permanent damage. Active infection, the 4-week cycles, the migratory things, you need more antibiotics. Autoimmunity is especially common if there's bands 31, less so 34, and 41 on the Western blot. With autoimmunity, you treat with immune modulators, and the best one, of course, being IV gamma globulin. I'll tell you in a second if I have time. If there's permanent damage, there's a bigger role then for rehab. But be cautious about surgery. Patients with active Lyme are prone to developing internal adhesions and scarring because of the effect of Borrelia on collagen. So be very careful. Keloid scars, for example, are very common. All right, now, we'll talk a bit about autoimmunity. Now, the IDSA camp believes that autoimmunity is the basis of all chronic Lyme. There's a little bit of the picture on both sides. It's not black and white, the shades of gray. But a lot of Lyme patients do have some autoimmune phenomena, and these type of things are not helped by more antibiotics. So for example, if you have a patient who's been through treatment and the 4-week cycles have stopped, but they're left with a neuropathy and they have band 31 on their Western blot, so you know what, maybe there is some autoimmunity going on. Or what if you have patients with a lot of neuropathy who still is infected? Well, you can have autoimmunity and infection concurrently. It's not one or the other. It can be both. And in this case, you use the immune modulators such as hydroxychloroquine and IV gamma globulin, which is definitely underutilized. Let me talk to you about the Lyme neuropathy. Do you have neurologists in the audience? Any neurologists here? Listen, everybody. Chronic Lyme disease is a disease of the nervous system, okay? That's the number one place where it hits. So you all need to have a good Lyme literate neurologist you can refer to and keep him or her very busy because that person is going to be your ally in getting your Lyme patients better. Almost every chronic Lyme patient has peripheral neuropathy, the numbness, the dysesthesias, the terrible pain syndromes that don't go away. They almost all have autonomic neuropathy, tachycardia, what they think are panic attacks, increased sympathetic tone where they feel like they're always on caffeine, orthostasis, poor gut motility, they call that Bell's palsy of the gut because it is a cranial nerve. Neurogenic bladder, erectile dysfunction. Skin temperature. For example, you might have a patient who's sitting in your office who's completely warm, and you look at their bare feet, and although their skin is warm, their feet are blue and cold, and they have good pulses. It's not a peripheral circulation issue. It's an autonomic nervous system not controlling the flow of blood. That's a sign of autonomic neuropathy. Now, there are a couple of interesting ways you can look for neuropathy. EMGs and nerve conduction studies, these are things that are called electrodiagnostic studies with the wires up and down the arm or the leg. In the Lyme patient, you're going to miss about 2/3 of cases of neuropathy because these electrodiagnostic studies look for demyelination of the large nerves, but Lyme will affect the small nerves that are not myelinated as well. Now, what also we do in America quite a lot is a skin biopsy, a single 2 mm punch biopsy of the lower extremity. Very simple. Dermatologists do this all the time. You can learn to do it. Doesn't even need a suture. And if you do it down a full thickness 2 mm punch, you can actually stain them and look for nerve fiber density in the skin and in the sweat glands. And we're now doing research. A pilot study was just completed. Now there's research to look actually at myelin stains of the nerves to look for direct evidence of demyelination. Also, you can do autonomic studies, tilt table tests, and so forth. Let me give you some pictures. This is what a skin biopsy looks like, the epidermal nerve fiber density. This actually came from a chronic Lyme patient. Panel A on top is normal, looks little dendritic branches. These are nerves stained. This is the bottom is a Lyme patient. You can see the nerves are pretty much absent in the skin. When you see this, you also can infer that it's an autonomic problem as well because it's the same type of fibers. Here's a similar picture of the sweat gland. Panel A is a normal and B is the abnormal one. You see much less nerve fibers. And here's a very quick look at the direct demonstration of demyelination. Again, electrodiagnostic studies miss 2/3 of Lyme patients. If you do them and add to it the nerve fiber density, sweat gland density, and then when this becomes available over the summer, the myelin staining, you can pick up almost all the cases. Now, if you have this, the treatment for this is intravenous gamma globulin. It's much underutilized in the Lyme community. It will help remyelinate the nerves. It'll help grow back these little dendritic fibers I showed you on the skin biopsy. And actually, we have evidence to show that in our serial studies. It's an immune modulator. Now, if you have this immune system that's so active with cytokines, you want to calm it down. If you use an immune suppressive, that's not a good thing to do during an infection. Using steroids, for example, make the Lyme get worse. But a gamma globulin will suppress the activity of the inflammatory cytokines. It'd be an anti-inflammatory without being immune suppressive. So you have the healing of the nerves, the remyelination of the nerves, and the regulation of the immune system, all the things you need for Lyme disease. In terms of other supplement you can do, R-lipoic acid has been shown to help heal neuropathy in diabetics, and we're using it now in our Lyme patients, and it has helped some patients. So we'll go to the end of this now. Treatment tips. Informed consent. You're going to do things with your patients that they probably never heard of before, that they might be uncomfortable with, and you might be uncomfortable with. Make sure that everyone understands what the goals are here. Full supportive measures. You'll hear an earful of this from Dr. Horowitz this afternoon. Choose a good antibiotic regimen based on logic and common sense. Close follow-up, patient diaries, office visits, physical exams, laboratory monitoring. You can't take care of a Lyme patient by phone. It has to be in person. And be prepared that regimens have to be changed and rotated over time. I could spend a whole hour on the supportive measures, and maybe one day we should. But when it comes to diet, it has to be a low glycemic index, low carbohydrate diet, and watch for food allergies. For unknown reasons, be it gut dysbiosis, effects of the immune system, or combination, almost every Lyme patient develops food sensitivities. Alcohol is absolutely not allowed. It makes the Lyme germs more active and more toxic and weakens your immune system. This balance goes in the wrong direction. Never any immunosuppressors if you can avoid them. If you need small doses of steroids to support a weak adrenal gland, that's fine, but the high doses for immune suppression, you really should avoid. If you have to take it for something like an acute optic neuritis, intravenous antibiotics for 36 hours before you start the steroids. In terms of nutritional supplements, there are a lot of things you can talk about. The ones on the slide are the basics. Good multivitamin to round it out. CoQ10 is important. The NT factor, I don't know if you heard of this, but it helps to put normal membranes back in your mitochondria. Of the things I've given my patients as a supplement, by far that is the number one thing they all can feel. After a week or two, it makes a huge difference. Definitely embrace this. You'll find it's remarkable. Definitely vitamin D if it's necessary, and the essential fatty acids. There's a specific exercise program that's outlined in my guidelines that you can easily read. The exercise program is not for rehabilitation, okay? It's designed to reconstitute T-cell dysfunction. It's been found that after aggressive exercise, T-cell function will dip to low levels, in fact, very low levels in some people, but then rebound after a period of time. In a healthy person, the rebound occurs 24 hours later. In Lyme, it's more like 2 to 3 days. So the idea of the exercise program in a Lyme patient is not rehab, it's to rebuild the immune system. So it involves a full body, not aerobic, toning program, an hour at a time, once, and then 2 or 3 days of no exercise. And you do it again, and then 2 or 3 days of no exercise. And over a period of time, it reconstitutes the immune system and your energy comes back. Again, I can spend a long time on this, but I don't have a long time, so I won't. When Lyme patients get sick, they must rest. They must sleep. It's when we sleep that our immune system gets recharged. And again, we want to build up this immune system. So sleep, unfortunately, is something Lyme patients often have trouble with. So have a good neurologist help you with good medications to get you to sleep well, because you have to have that deep sleep to regenerate the immune system. And this is a tough illness to go through, tough treatment to give out, tough treatment to take. And it takes its toll on people, on families, on friends. And psychological and emotional support is important. And it's not because you're crazy. It's not because the patients are nuts. It's not true. But they've been through a stress. It's almost like an ongoing traumatic stress disorder. And getting emotional support is actually something important. Now, when I close, I do want to give one last shout out to iLads. You all should become members of iLads. It's an international society. We have people in Europe as well as Australia and America. We have this training program that iLads will actually pay you money to be trained. Have educational DVDs, references on the internet. It's a great organization to join, so I encourage you all to do so. And I thank you for your time and for your overtime. And I'll talk to you later.